In our previous session, we talked about the structures of the respiratory system. Today, we're going to talk about the mechanisms of breathing. We've got two stages to breathing. First stage is inspiration. So this is breathing in. And the second stage is expiration, breathing out. Inspiration is an active process. So we need muscles to contract for this to occur. Expiration at rest is passive. But if we're doing heavy exercise or you are forcing air out of your lungs, it can become active. So when forced or in exercise. This movement of the cycling of inspiration and expiration is called ventilation. So ventilation is this movement of air in and out. Now the lungs themselves, as we said in our previous session, can't move on their own. They're spongy, they're elastic, but they can't move on their own. They are going to move through the actions of the diaphragm and the intercostal muscles. So when these muscles contract, that will allow inspiration and expiration. So during inspiration, this is when the lungs are going to expand, and they will expand and air will be moving into the lungs because we've got a reduction in pressure inside the lungs below atmospheric pressure. During expiration, the lungs will reduce in volume, so become smaller, and this leads to an increase in pressure above atmospheric pressure, and the air moves out down its pressure gradient. So if we look at inspiration in a bit more detail, remember we said it is an active process. So muscles have to contract for inspiration, and it's an active process, and we mentioned this in structures involving the external intercostal muscles between the ribs, and that will account for 25% of your inspired air, and the other is the diaphragm, and when this contracts it accounts for 75% of the inspired air. And what's going to happen is, first of all, the external intercostals will contract. Muscles contract, so they pull, and when they contract, they pull the ribs up and out. So ribs go up and out, and what this does is create more space in the chest cavity. At the same time, the diaphragm goes from the domed shape to the more flattened shape, so it flattens and contracts and flattens, and this means the entire volume of the chest, of the thoracic cavity, increases. So when you've got an increase in volume, this means you have a decrease in pressure, and the pressure inside this chest cavity decreases below atmospheric pressure. So this means that the air outside your lungs is at higher atmospheric pressure than inside your lungs, and it means that air is drawn into the lungs, and then the alveoli will inflate with this air that is drawn in. Expiration is a more passive process, especially when we're at rest. So when you're sat listening to this lecture now, watching this lecture now, your expiration is a passive process. So it's much easier than inspiration. You've got gravity to help, so the external intercostal muscles relax. The ribs, gravity helps to bring the ribs down and in. The lungs are elastic as well, so when they stretched when you inspired air, you've got this recoil. So this elastic recoil helps force the kind of recoil the air out. That's when we're doing passive expiration. We do have what we call forced expiration, and you could do this yourself if you sit now and you try to breathe out as much as you can. So that's what we mean by forced expiration. When we do enforced expiration, you've got the internal intercostal muscles, and they will be contracted to help force the air out. Also, your abdominal muscles are also helping as well. So if you do that forced expiration again, put your hand on your abdominal region, you will feel your muscles contract as well. And they are helping to force the air out and also helping to force the diaphragm muscle up. But that's only in heavy exercise or when you are forcing the air out. Most of the time, expiration is a very passive process. So if we look at passive expiration in a bit more detail, external intercostals which were contracted for inspiration now relax, ribs move down and in, gravity helps. Diaphragm has relaxed back to its dome shape. So the overall volume of the chest has decreased. Now, because the volume has decreased, that means the pressure inside the chest cavity has increased, and it's increased above atmospheric pressure. So this means air is forced out of the lungs. But like I said, this passive doesn't need any energy, any extra energy at all. An important chemical we have to help us breathe properly and for our lungs to function properly is called surfactant. Now, surfactant is a phospholipid protein complex, and it lines our alveoli. So here's a cartoon sketch of an alveolus, and you've got this surfactant layer secreted internal to this alveoli. And what it does is it lowers surface tension. Without surfactant, when you breathed out and your alveoli collapsed, they would collapse like this and they would stick together. And then when you try to breathe again, they would find it really hard to unstick and inflate again. And what the surfactant does is it lowers the surface tension so that you can inflate and deflate the alveoli perfectly fine when you're breathing. This is really important when newborns are born, or babies are born for the first time. So when a baby is born, before the baby is born, when the baby is a fetus, the fetus gets all of its oxygen across the placenta through its umbilical cord. When the baby is born, it takes its first breath, and that first breath is very hard for the newborn baby. It's 15 to 20 times more forceful than a normal breathing because the lungs are stretched for the very first time, and that surfactant is needed so that the lungs can stretch. Without surfactants, the second breath would be also just as difficult. So that again, the second breath would still be 15 to 20 times more difficult than normal breathing. But because the baby has surfactant, after that first very difficult breath, then it can breathe perfectly normally. If it doesn't have surfactant and continues to find breathing so difficult, that's not going to be sustainable for the baby. Now, in full-term babies born after proper pregnancy, not a problem. They have surfactant. This is a big problem in premature babies. With premature babies, they start during pregnancy, the fetus starts to produce surfactant between 24 to 28 weeks of pregnancy. And it's not until 30 weeks of pregnancy that sufficient surfactant is made so that if the baby is born after 30 weeks, then they've got enough surfactant for their lungs to work properly. And this is the reason why premature babies often have breathing problems. To overcome this, doctors can do a number of things. So if a mother is at risk of going into premature labour, the mother can be given steroids to help mature the baby's lungs, or basically tell the fetus to start producing surfactant because it might be born soon. The other option it can do is after the baby is born prematurely, the baby can be given oxygen through its nose or through the crib it's put in. The baby could be ventilated, so have a breathing tube put in, so you could ventilate the baby. But also you can spray artificial surfactant into the lungs, which is kind of mind-blowing. So this artificial surfactant has been developed that you can spray inside the premature baby's lungs to make it easier to breathe. and reduce the likelihood of lung damage. So this breathing problem in newborns is called newborn respiratory distress syndrome, if you want to look at it in more detail. And because of advances in artificial surfactants and ventilating babies, premature babies have a much higher chance of surviving and being healthy than they have in the past. One final factor to mention is how we control our breathing rate. So we talked about how we control our heart rate, and that occurs in the medulla oblongata of the brainstem. The control of breathing also occurs in the respiratory center in the medulla oblongata. And in order to sense what our lungs are doing and what's going on in our respiratory system, we have a number of receptors. We have stretch receptors in our lungs, and they say how stretched the lungs are. So if the lungs are very stressed, then that means that the lungs are working very hard, so perhaps the breathing rate needs to be increased. So the stretch receptors will notice that and send the information to the medulla oblongata to increase the breathing rate. You've also got chemoreceptors, chemical receptors, and these are in the medulla oblongata, in the carotid artery, and in the aorta, and they monitor carbon dioxide levels. So we don't monitor oxygen levels in our blood, we monitor carbon dioxide levels in our blood. And if the carbon dioxide levels are too high, this means that the breathing rate needs to increase to get rid of this excess carbon dioxide. We don't have to think about breathing. It's an involuntary action. We can hold our breath though. So when we hold our breath, we are suppressing this involuntary system. So we can decide to do this, but you can't kill yourself by holding your breath. Because what will happen if you hold your breath for too long, you will lose consciousness. And once you lose consciousness, your medulla oblongata will take over the involuntary control of your breathing. You'll breathe again and recover. In the next session, we're going to talk about gas exchange in the alveoli. Thank you.